On this Veterans Day, we share the health journey of a veteran who also happens to be a neurologist here at the University of Kansas Health System. He was injured in a blast while serving a tour of duty, changing his brain. This morning, we share his journey to his diagnosis and the treatment that is finally working. Good morning, I'm Alexis Del Cid. Welcome to All Things Brain Health. On this episode, we have three neurologists with me on the set. One of them is our featured patient, Dr. Andrew Jarzin, who is also a veteran. And after serving his country, he found himself fighting a very different battle with seizures. We will share his diagnosis, something called post-traumatic temporal lobe epilepsy, here in just a moment. But first, let's get to today's morning rounds. The University of Kansas Health System is honoring patients here in the hospital who also happen to be veterans. And Chaplain Ben Hayden, is also known as Lieutenant Colonel Ben Hayden, is taking part in a special ceremony and joins us virtually this morning. Chaplain Ben, you currently serve in the Air Force as a Reserve Air Force chaplain. How many years have you been in the Air Force?
Yeah, good morning. Yeah, I've been serving for next month will be 24 years and stationed at Scott Air Force Base, which is a little outside of St. Louis on the Illinois side.
Thank you so much for your service. What called you to serve?
Well, I had a recruiter that came my junior year of college and talked about the Air Force, and at that time kind of felt led to overseas missions, and they were going to help pay for seminary, and thought the ministry looked exciting, and I've kind of been taking it 1 year at a time, 24 years later. So,
can you share more about your role as Air Force chaplain?
Sure. Yeah, I am what's called an IMA, an individual mobile augmentee, and so I'm at the command chaplain's office. So I do a lot more leadership stuff. So last year I was deployed for all of last year, so I wasn't at KU Medical Center at all last year, and really blending my medical and hospital experience with my military experience. So I led two exercises where we trained our chaplain corps how to do triage, how to put patients in the back of an airplane, how to take them out, how to also build a chapel tent in a 50-bed hospital. So it was really quite fulfilling.
We know that there's a special ceremony this afternoon at the Battenfield Auditorium, and then you'll be visiting our inpatient veterans. What do those visits look like?
Well, we'll have some of our veterans from our Veterans Resource Group that will be volunteering and participating with some other employees from the hospital. So really kind of gathering a team and going into the room of a veteran and just really honoring them with what we call a challenge coin. For those who have served, know what those challenge coins are, and it's really for a job well done. But it's really quite rewarding just to take a few moments and to honor our veterans. And some won't necessarily be able to talk, but also with family members there, it's just a nice way to honor them and thank them for their service.
Oh, absolutely. When they're in the hospital, they need to be honored and remembered everywhere. And when you're in the hospital, it's important to have those things in place. In just a few weeks, remembrance wreaths will be laid and placed across the nation to honor the fallen and living service members. It must take a lot of people to pull this off, Chaplain Ben.
Yeah, it does. This is just one way to continue to give back for our fallen soldiers through the wreaths across America, whether that's through sponsorship or volunteers. So always looking for extra people to help in these situations too, to honor those that have gone before us.
For people who are watching this program from home, do you have any advice on nice ways that they could honor a veteran today?
Well, I think just thanking people for their service, that's always a nice way. I think most of us as veterans feel a bit uncomfortable with that as well, of how to respond. But I think just acknowledging for those who have gone before. I think our newer veterans don't necessarily wear the hats around, so sometimes you don't really know. But oftentimes, for those that are wearing the hats around the community, or within the health system. It's just a nice way to pay tribute to them and tell them thank you. We always enjoy a nice thank you.
Chaplain Ben, thank you so much for joining our program this morning, and thank you for your service.
Thank you.
On today's program, we'd also like to welcome another veteran, our patient today, Dr. Andrew Jarzin. Thank you for your service. Would you consider yourself one of the new veterans? Because you look pretty young.
Yes, yeah, I would consider myself one of the new veterans.
What inspired you to enlist? And what branch of the military did you serve in?
I enlisted in the Army. 9/11/01 was in my senior year of high school, so that was a big inspiration for me to take the leap into service.
And how long did you serve?
I served just under 5 years.
When did you decide you wanted to be a neurologist throughout all of that?
It was actually on my tour of duty. Saw a lot of blast injuries and all the consequences that can come from that. And I wanted to help people.
And you sure are. You're helping
Thank
people. You specialize in dementia
Yes.
and Alzheimer's disease. Thank you for doing that as well. We need more specialists in that area and more research. And we're going to talk about you yourself suffered a blast injury, which is why you're our featured patient today. You're one of 3 neurologists on the program, and it's rare to have one of our neurologists also join us as a patient. So thank you for sharing your journey. We also want to welcome your epileptologist here at the health system, Dr. Patrick Landazuri. Thank you for being here. And we're very honored to have Dr. Vika Singh on the show today. Dr. Singh does not treat Andrew Jarzin, but he's the neurology section chief at the Kansas City VA Medical Center. And it's a holiday, and you came in on the holiday, so thank you for doing that.
It's an honor to recognize the veterans on the Veterans Day. So glad to be here.
He treats veterans just like Dr. Jarzin, so you'll have some valuable expertise to share in this conversation. How soon after the blast injury did you notice a problem, and how far into serving were you? What age were you at?
I was 21 years old when it happened. I don't think I really noticed anything until I was in my 2nd year of residency. When I had an issue that caused me to be admitted to the hospital. This hospital, actually.
This hospital.
Yeah.
So how many years had passed from the blast injury to when you had your first episode?
It was about 14 years.
14 years.
Yeah.
So it was a latent problem that was just in you. What was that like, and what happened?
What happened was I was trying to go to bed after a long shift, and I noticed that something didn't feel right. I had an impending sense of doom.
Like anxiety?
The best way I could describe it is if you knew that there was a car crash that was going to happen right in front of you on the highway as you're going, 65, 70 miles an hour. And it's all in slow motion. So this impending sense of doom is what I experienced, and I left my bed and sat on my couch and looked at my now wife. At the time she was my girlfriend, and she could tell something was wrong, and that was kind of the last thing that I remember.
She just said, "Honey, are you okay? What's happening?" And then lights out for you?
Lights out for me. I have no recollection or awareness of anything really that happened for several days.
What does she say happened? Now that you know what happened, what was that?
So she explained to me later on that I had my eyes and my head turning to the right. My right arm was flexed, kind of up, and my right leg was extended outward. That lasted for 15, 30 seconds maybe. And then after that, I could not speak. She's an ER nurse, so she kind of had an idea of what was going on at the time, thankfully.
Did she also work here at the time?
No.
Is that why? Okay. Thank God you were dating a nurse. That's great.
Yeah.
So what did she do next?
She essentially gave me some medication that would help, that she's familiar with from her time in the ER, and then brought me to the nearest emergency room, who then did their basic workup that they could do and transferred me here to KU.
How did you connect the dots to then make this appointment with Dr. Landazuri?
Well, I'm familiar with Dr. Landazuri as an excellent epileptologist from my time as a resident here, and just kind of running through my symptoms with him, I was able to get in and make an appointment with him.
So, Dr. Landazuri, how did you think what Dr. Jarzin just described happened to him? As a layperson, I picture when I hear of a seizure or epilepsy, I think of what you see on TV. The seizures and the convulsing. You're talking about your arm this way and your legs straight out. How did you know that that was epilepsy?
Well, actually, I mean, it's kind of easy when you're asking a neurologist what's going on. So Dr. Jarzin already kind of knew what was going on.
So you already knew this might be epilepsy?
Well, in my confusion afterwards, my wife told me that I motioned for a pen and a paper.
Really?
And she had an idea, as I said, of what was going on. But on this paper, I wrote seizure, and she asked me, "How do you know?" And then I wrote only neurologist in room.
Do you still have that piece of paper?
I believe she does still have that piece of paper.
Did she frame it?
No, not yet.
It's not not a memento you want to frame right now. That's
I'll get around to it.
wild. And so, Dr. Landazuri, how did you put it that this was a blast injury from 14 years earlier? How did you figure that out?
Well, so the epilepsy part is fairly straightforward for him. He gives like an amazing classic description of temporal lobe epilepsy. And then the question that physicians ask themselves is why? And so sometimes we're able to understand that, sometimes we're not. And so with Andrew, you know, we kind of said, well, what happened, you know, back when you served? And he's like, well, I had this blast injury, and, you know, you can't know 100%, but he has no other risk factors, so it seems the most likely explanation. The
temporal
post-traumatic part. Yeah, well, the temporal lobe is straightforward from the symptoms themselves, but the reason, the post-traumatic, that's most likely just given his history.
And what's the other kind of you've got temporal lobe epilepsy, and then is there a traditional form? Is this one more rare?
No, actually, it's most common. So
Okay.
a temporal lobe, just based on that impending sense of doom he described, and then
Wow.
with the right side of his body being most used, it would implicate the left temporal lobe then. So, yeah, just a kind of a classic epilepsy case, truthfully.
I still can't wrap my head around you being able to write that down. Only neurologist in the room. So you still had a sense of humor.
Apparently.
At some point.
Apparently.
Dr. Singh, is this a common thing that you see from your patients who've suffered blast injuries?
Yeah, it's pretty common, particularly in our patient population. So blast injury is a signature wound of the Iraq and Afghanistan war, or after 1992. We see a lot of patients or veterans with blast injury. So it's pretty common, and so the prevalence of epilepsy, as in general population, say about 10 to 20%, depending upon the patient population that you study. And in veterans, about say 1 to 3% of patients who have epilepsy have it because of after TBI have the post-traumatic epilepsy.
Post-traumatic
And
epilepsy.
out of all the epilepsy patients that we see in the clinic, say about 13 to 15%, they will have it because of TBI, prior TBI. So the highest incidence or prevalence of post-traumatic epilepsy is after moderate or severe TBI, or TBI where there is penetrating injury to the brain, like a bullet or a shrapnel, or bleeding in the brain. But oftentimes mild TBI and blast TBI, which often has no abnormalities on brain imaging, is ignored, or there is lack of awareness about it. And we see a lot of veterans with blast TBI who go on to develop epilepsy later on in life, and the latency period is long. So as you heard Dr. Jarzin, 14 years after. And various studies have shown that it can be as long, the delay in presentation can be as long as 40 years or 4 decades. So
40 years.
It can be. So the
wow.
largest studies that they did in patients with TBI, they found that the risk is highest early on, but it never goes down to the risk of epilepsy in general population. It's always elevated.
Should all veterans who've suffered a blast injury in their lives be seeing a neurologist just to lay the groundwork of having that relationship?
I'm glad that you brought that point. That should be ideal. And so in TBI clinic, there's work to do to spread some awareness about that. Okay, when you see a patient with TBI, even remote TBI, keep in the back of your head about the possibility of post-traumatic epilepsy and the subtle ways it can present. As Dr. Jarzen said, that impending doom and some other less recognized symptoms than what you see on TV. So we have to spread some awareness in the TBI clinics and provide veterans access to those specialized TBI clinics so that epilepsy can be recognized early on.
Do you also describe impending doom as one of the precursors to an episode? It's just such an interesting description, the feeling of impending doom that both doctors have described.
Yeah, so that's just it's generically called an aura or a focal aware seizure. Those are the two terms, and so
different from a panic attack. Sometimes I'll have those and I'll feel this impending doom, but so they're describing something different than that.
Well, no, so it's well, I've never had either, so it's hard for me to say, but I would suspect it's a similar symptom. It's just a different cause. So panic attacks are far more common than temporal lobe epilepsy, thankfully.
Sure, yeah.
But it just comes with what's going on at the time.
Dr. Jarzen, do you think, looking back now, that you had subtle signs that something was wrong after that blast over the course of the 14 years?
So it's funny you ask that. After my discharge from the hospital here and getting my diagnosis, I actually looked back through my VA records and since I got out, and I had brought up episodes of missing time several times around 2010, 2011.
Can you talk more about what does missing time look like?
So it's that period of unawareness that I experienced after the major seizure that I had that actually brought me to this hospital and eventually got me my diagnosis. So
you'd be sitting in a room and you'd realize an hour had passed and you didn't know what had just happened for that hour?
Pretty much.
Oh, wow. That must have been so jarring.
Some of the other symptoms that I, looking back, noticed that I've had for a while is this sense of deja vu, which, as Dr. Landazur was talking about, is another type of aura. So if you get this strong sense of deja vu, it's another kind of aura.
It's interesting. Dr. Landazuri shared an image with us. This is not a picture of Dr. Andrew Jarzen's brain, but it does show what Dr. Jarzen was experiencing. Now, Dr. Landazuri, I just see that little red arrow. I can't see any difference between that side and the other side. What are you seeing that leads to a diagnosis?
Yeah, so on that image, the red arrow points out it's kind of like a horizontal white blob. It's called the hippocampus. And if you kind of look over on the opposite side, you see a similar, instead of a kind of a light gray, it's more of a dark gray blob. That's the other hippocampus. So where a seizure starts, it swells, just like, if you get a punch in the shoulder, you get a bruise on your shoulder. So imagine a seizure is punching the brain, and so you just get a little bit of swelling there. And so for people that have longer seizures, you can get that kind of pretty subtle MRI finding that you got to kind of know to look for it. Otherwise, you might just kind of dismiss it.
Sure, just a little bit, just a little bit lighter.
Yep.
And the blast injury wasn't something that had you in the hospital afterwards. You were saying you walked away from it.
Yeah, I was out for an unknown amount of time afterwards, and essentially there was no hospitalization or treatment afterwards.
So that could be so many people watching where you don't, and there you are, a young Andrew, younger.
That was after that deployment on a training exercise.
I like that picture. Gosh.
It's an old one.
It's an old one. Oldie but goodie. You said that we inspired you to try to find some of your old pictures trapped on an old computer.
Yep.
You want to save those. Did being both a neurologist and a patient shape the way that you approached and digested this diagnosis?
Absolutely. I think it gave me more of an empathy of understanding of what patients and their families go through. In the sense, the scariness of this diagnosis and the challenge of actually diagnosing it. When I had mentioned that in my prior VA records, I had mentioned this missing time.
Right.
It's nothing that the prior doctors did wrong. It's just a challenging diagnosis to make in the setting of everything else that veterans go through.
Sure. Is there often a delay in diagnosis?
Unfortunately, yeah, for epilepsy there often is. It kind of takes a pretty astute physician, maybe astute's not the word, but just observant one, just to kind of say, well, maybe, people have all sorts of symptoms all the time, and if we just ascribed everything to epilepsy, we'd be diagnosing too much epilepsy.
Right.
So, in isolation, any one symptom is not necessarily diagnostic besides a convulsive seizure typically. But if you can kind of say, well, we have some missing time, well, we have a moderate traumatic brain injury, well, we have deja vu, then you start putting that together. But you have to ask the questions, and patients don't know to tell us these things because, as you kind of said, when people think of seizures, they think of seizures on television, which is typically the convulsive part. And all these non-convulsive seizures, which are far more prevalent in many ways, if people don't know about them, they don't know to tell you about them.
Dr. Singh, what are the most common challenges that you see treating veterans with post-traumatic temporal lobe epilepsy?
So veterans are a rather unique patient population, and I spoke about the latency. So by the time that we see those the veterans with epilepsy in clinic, post-traumatic epilepsy per se, they are often 10, 20, 30 years out. So they are 30, 40, or 50 years of age, and by that time, they have many other medical conditions, and they are on many other medications. So the problem with medication interactions, side effects, or what we call as polypharmacy and polypharmacy-related side effects is a big challenge.
What's a polypharmacy?
Polypharmacy is poly means many medications. So all those patients are medication for blood pressure, heart disease, prostate problems, all those things. And when we add a medication for seizures, they possibly interact with those medications and can make those worse. Another aspect is veterans who have had TBI, they also have complications associated with TBI.
Traumatic brain injury.
Traumatic brain injury, yes. So they may have cognitive difficulties, and some of them are very subtle, like memory difficulties, lack of concentration, ADHD, balance, gait issues, all those kind of things. And some of the medications that we use have those side effects as well, so it becomes a little bit challenging.
Sure.
And the cognitive difficulties are the big problems that we see, is that we have to bring the patient's family members and caregivers also in the clinic so that we can provide them that information and that insight, is that the information not only about seizures but also other side effects or complications associated with seizures as well as traumatic brain injury.
It takes the whole family
to
help notice things and get help for the person they love most in the world. We have some great questions and comments already coming in, so if you have a question or a comment that you'd like us to read out loud on the program, you can send it to us on YouTube or Facebook, and you'll find all the links on how you can connect with us right now there on your screen. Dr. Jarzen, when it comes to the medications you took, what was the hardest part for you going through various attempts at medications that failed before you found one that worked?
I think it was just the repeated seizures, really is the hardest part. Because once you have a seizure, there's this 6-month window that you have to be seizure-free in order to do things like drive or go swimming by yourself or operate heavy machinery if you're a construction worker. Thankfully, I'm not. But driving was very difficult.
And you have patience that you're seeing, so that would be hard. So do you think that you were having, when you describe how you noticed those lost time episodes before this, were those seizures?
Looking back, potentially.
Okay.
I can't say with 100% certainty.
After your first seizure, did you have obvious ones after that kept happening? So did that kind of kick off a string of very obvious seizures?
It kicked off what I would consider to be just more observant of myself, and my wife to be more observant of me.
And not being able to drive would be very hard. What were some of the side effects of the medications that you had that you didn't like? Were there bad side effects?
Most medications carry side effects. Some of the ones that I experienced were just an irritability on one of the medications. Another one of the medications started to cause me to have some heart palpitations, so I was pulled off of that one.
Not good. Neither one of those is a fun side effect to have when you're trying to do things in your life. Dr. Landazuri, Dr. Jarzen developed seizures from the blast injury while he was serving. How many of your patients have post-traumatic,
post-traumatic temporal lobe epilepsy?
Yes. How many patients have that from other injuries to their brain, say a car crash?
I don't know if I could put an exact number on it, but yeah, things like car crashes can cause things. So basically, the brain rests on the base of the skull. And so Dr. Jarzen doesn't have this, but if you get a small hole in the skull, like just a few millimeters, the brain kind of pokes through it kind of like a hernia would, and so we call that an encephalocele. So that's a common cause, and it can be from subtle things or obviously more major things like car accidents.
That's fascinating. I want to get to some of our viewer questions because we have some very good questions and comments. Ruth wants to know, are there follow-up appointments with wellness exams after returning from deployment for any service member? What about senior citizens who have wellness exams and answering the Medicare questions? Want to take that one?
As far as follow-up appointments, there is a general, at the time, again, this was long ago, and we weren't, the powers that be, I guess, were struggling to work with the amount of injuries that we were seeing come back. So there was generally just one quick wellness visit, just a general physical after you get back, but no real follow-up after that.
That makes me sad.
It's a lot better now.
That. Yes, it sure is.
We've learned, and like I said, it's a lot better now.
Dr. Singh, I want to ask you, what inspired you to work with veterans and help veterans at the VA?
So it's, as I said, it's an honor to serve the veterans who serve the country, and veterans are like, they are very thankful for the care that we provide them. The patient population is unique, means they are very thankful, they have gone through a lot, and they have appreciation for every aspects of life, including the care that is provided to them. So it's really a pleasure. I joined VA right after I finished my fellowship, and one of the reasons was because I worked at the VA prior to going into residency and fellowship. So I really liked the atmosphere over there and the environment and the interactions that we have with the veterans. So that was a big driver.
It's beautiful. Thank you for doing that. Dr. Landazuri, I have a question from Lauren. Lauren wants to know, are there any epilepsy triggers that even medication can't prevent?
I think that the medicines themselves don't treat triggers. They treat the patient's brain. And so some of my patients, they go a period of being seizure-free and they say, okay, maybe it's gone, and they stop their medicines, and unfortunately they have seizures. So I think the important thing is that the anti-seizure medicines unfortunately do not treat the epilepsy itself. They don't fix the epilepsy. We wish they did. They don't. So the way I kind of explain to patients is the medicines build a wall every day around their epilepsy in their brain to prevent the seizures from starting.
Is there anything that you can or can't do that you can't do today that you worry about because of the diagnosis?
Not really.
Is there anything you avoid because you fear it will trigger something?
I do avoid, having a drink every now and then. With if I'm going out to dinner, I avoid cocktails or wine or anything because alcohol can be a trigger.
Which is what we hear
general,
more and more from neurologists. Neurologists are saying stay away from alcohol for all brain reasons. What's your take on drinking and just the brain?
Yeah, particularly for epilepsy, some patients clearly have alcohol as a trigger, and many don't. So patients pretty quickly figure out which camp they're in, and then they self-choose, as it were, typically. As for general alcohol in the brain, I mean, I think, in terms of like dementia, actually Dr. Jarzen's probably better at this than I am. But clearly, chronic or even moderate alcohol use can have some dementia risk.
Yeah, it's like throwing gasoline on a fire.
Gasoline on a fire, that's what drinking is like.
Yeah. If a patient already has dementia and they drink, it's throwing gasoline on a fire.
I have one question for Dr. Singh from Jeremy. When working with veterans with epilepsy or brain injuries, are there more intricate interactions between epilepsy and other brain stuff that veterans deal with, like isolation, PTSD, or how hard the transition is back into civilian life?
Yeah, so it's a very important question, and I can talk for hours about it, but so the last part of that question, reintegration. So reintegration of veterans into civilian life, that VA has worked upon it for a long period of time, at least 2 decades now, and is still working on it, trying to figure out how to reintegrate the veterans to the civilian life, and that becomes particularly harder when your whole social or vocational life is impacted because of seizures. So you can't do certain work, you can't drive. You can drive if the epilepsy is well controlled, and that's possible to do it in this day and age to control the epilepsy. But those factors significantly impact reintegration. Other aspects, like I alluded to earlier, so the veterans with TBI and post-traumatic epilepsy, they very frequently have other issues as well. So post-traumatic headaches, sleep dysfunction, so insomnia, hypersomnia, or excessive sleep, and night PTSD and nightmares. So the moment they go to sleep, they wake up after a couple of hours, so they are not having a good night's sleep, they are not rested. And we all know that lack of sleep or disruption of sleep-wake cycle will make the epilepsy worse. They will have breakthrough seizures. Also cognitive difficulties, so TBI, and particularly mild TBI, the recognition that even mild TBI can have significant cognitive impact is less, the population is less aware about that fact. And so there are multiple factors: cognitive impairments, sleep issues, PTSD, mood disorders is a big one. So a lot of veterans with epilepsy and post-traumatic epilepsy have depression, anxiety, irritability, or anger that can get worse with the certain medications that we try. So we have to carefully choose those medications. So post-traumatic epilepsy is not just seizure alone, but a whole lot of things that come with that. So
it's a whole host of things. Dr. Jarzan, I want to start with you for today's takeaways. What's the one message you want our viewers to take away from this discussion?
If you're a veteran out there and you're struggling, please go ahead and get help. Put the pride aside. You know, if you don't feel like you deserve it, your family deserves it, that you get yourself better.
Dr. Singh, you're nodding your head.
Yeah, no, that's very important. I'm so glad that you said that, because the ethos in service is that when you get knocked down, get up and keep doing what you're doing. But it's very important to take care of the epilepsy and the TBI and the complications, like you very well said, for your family also, not for only for yourself, but for your family as well.
Dr. Landazuri?
No, I mean, I've never heard it said so well, truthfully. I mean, people who give their lives in service expect just to keep going, and I think the idea of, like, if you're not going to, you know, do it for yourself because, like, I'm just going to keep doing it, you know, other people depend on you, and so I think that's an equally effective way for people to get the care they deserve.
Dr. Jarzan, thank you for coming on the program and sharing
Thanks.
your journey, and thank you for serving. We are so grateful.
Thank you.
Dr. Singh, Dr. Landazuri, thank you so much for taking time to join us today. And to our viewers, thank you for joining the conversation. Please be sure to thank a veteran today, give them a hug, buy them a cup of coffee, do whatever you can to make their day brighter, and we'll see you back here tomorrow morning. On the next Open Mics with Dr. Stites, 18 years ago, Sherry Kennedy had limited options for cancer treatment. The survival statistics far less encouraging. We share the evolution of treating multiple myeloma tomorrow at 8 a.m.